So we do have a few minutes for questions. If you guys want to approach the microphones, and we can take some questions and comments. And we'll start with you. And please introduce yourself as well.
My name's John Deere. I'm from Geisinger Health System, and I'm the co-PI on the Open Notes initiative that you mentioned with the folks from Beth Israel and Seattle and Harborview. What a incredible talk, and thanks so much for sharing that. Am I on now?
Thank you.
Is that better? Yes. Sorry about that. So again, just an amazing talk. Thanks so much for sharing all of that. In the process of the Open Notes initiative, we looked, and about 20% of folks shared notes with their family members. And we are in the process now of beginning to think through our next iteration of the sort of investigation, and caregivers is a big focus. And I'm just curious if you would comment upon what you think it would mean to families. All right, we know that patients really value the information, but we are still in that process of really understanding what caregivers need in terms of information and how that's going to be transacted. I'd love to get your thoughts.
Oh, thank you. It's a great question. I think that family members are oftentimes, even when we're thinking about patient-centered care, are still a missing piece of the puzzle in engaging patients and families in care. Especially, I think even in my own clinical practice, one of the mistakes that I see some of my own colleagues make or my residents make is that they may be great at with the patient, but they kind of ignore the family member who's sitting in the room. And I think we forget that, more than half the time probably it's the family member, it's the concerned wife who's motivating a patient to seek care. And they really, in addition to other members of the community, are going to be key tools for us to gather more information about kind of how things are going for a patient. And also, I think, to make sure that our interventions are the appropriate ones. So I think there's fantastic opportunities there, and I think people will be really grateful to have that information accessible to them.
Hi, I'm Dave DeBronkart, and I have not a question, but comments. Jonathan, your story in health affairs, unbelievable. A few things I want to toss in. When my mom had her hip replaced a year and a half ago, at her transfer to rehab, right, because they didn't have electronic medical record transfer, so the stuff had to get printed out and typed back in, and they were not interested in proofreading, so her hyperthyroid showed up as hypo in the new system, potential disaster. My two, what I call alpha sisters, were on top of everything, and the patient and family engagement there saved the day. It's really clear that's one instance of patient and family engagement taking a burden off the providers who are not supported by good systems, good technology. Getting patients on involved in teams, in change teams. I'm going to be speaking a couple of months at Kingston General Hospital in Ontario. They have gotten it into their practice now to involve patients on every team, whether or not it apparently is something that directly affects the patients. Well, on hand hygiene, their hallway observers, the so-called Purell Nazis, noticed 30 to 60% compliance on the part of the physician. By the way, why do we, with patients do we call it compliance, and with clinicians we call it quality of care? I've got a point here. We have a cultural disconnect, and I'm not complaining here. That in my TED Talk, I didn't say this place sucks or anything like that. I said, look, let patients help. So the Kingston General Hospital, the hand hygiene team, one of the patients said, what we ought to do? Take each unit's numbers and post it on the door going into the unit. Shocking idea. Within 6 months, the hospital's up to 92% hand washing compliance. Right? What is keeping any of us from doing this everywhere else? And one final thing, and Kristen, you really should talk about your definition of patient-centered. But there was a Dutch IVF clinic, in vitro fertilization clinic, that gave their patient community a wiki in 6 months to talk, said, what do you guys want? And the third thing on the list after we want more attempts at fertilization. The third thing was we want empathy from our doctors, not just more information. And the fourth thing was separate waiting rooms for families who's conceived. So we've got some, I was saved by great medicine, and I think Gawande blames penicillin, right? He wrote an article where he said that this medical miracle of penicillin made us look to the lab for all value in healthcare. But I think what I'm hearing here is that there's great value to be had also from listening to patients. And so, thanks.
Thank you, Dave. And I just want to say one thing, which is Dave and others, there are a number, we made a concerted effort as a planning committee to reach out to patient and family representatives, individual patients, family members, and consumer organizations. Dave is one of those. We're grateful for you being here today, and we do have a number of you. Sorry, I must have to get closer. Either that or we have to turn the sound up in the room, because I'm going to break this microphone. But anyway, I just wanted to give a shout out to the patients and families and consumer groups here today and encourage you to do as Dave has done and speak up as the day goes forward. Did you want to comment?
Yeah, thanks for your comments. Again, I think your important example really underlines, first of all, how common this kind of experience is. One of the things I think I've noticed about these important mechanisms of feedback is that we probably really need to look to other sectors, whether they're wikis or other mechanisms, for thinking about how other sectors develop products and services with the user in mind. And I think that's a great example. The other thing I would say is when you kind of went through the list of priorities amongst patients for IVF clinics, is that it actually highlights a little bit of a danger zone, at least on the clinician side, which is that for the most part, I really do think that physicians and nurses try to have their patients' best interests in mind. There's a professional ethic there that, for the most part, we all try to follow. The problem is that you get into this conceptual shortcoming when you think that you can intuit actually what a patient needs. And when you start finding new mechanisms for listening to patients, you get really surprised about what some of the shortcomings in your care are. So we really need to develop those more. And then when I think about physician and healthcare provider engagement, that's a real intellectual challenge that we have to confront in our field.
I just wanted to thank you, Dr. Welch, for sharing your story. It was very compelling. And I have a story regarding my father that's eerily similar to yours. I'm from Bangor, Maine. I'm an independent patient safety activist and advocate. I'm a liberated, retired RN, so now I can say whatever I want. I've been a recent cancer patient, and I'm the survivor of a hospital-acquired MRSA victim. The difference between your mother's case and mine is that I was sitting in the room when he went into sepsis, septic shock, under the nurse's nose. She was in the room doing electronic records. And my mother and I returned from lunch, and I noticed that he was gray, ashen-colored, and somnolent. And she said, oh, he's just worn out. He's worn out because he just had a lung scan. He just got back from a lung scan. And I said, this is different. Oh, I think he's fine. So I raised a ruckus. You asked what we can do. In the words of Lisa McGiffert from Consumers Union, you raise a ruckus. If you don't have a cord to pull and to get the team there to take care of your loved one, you raise a ruckus. You can do that in a quiet, nice way, or you can yell if you have to, but that's your loved one. And that's their life that's in the hospital's hands. And if you know the difference between them being okay and them not being okay, and who knows better than family, seriously, then you speak out and you don't take no for an answer. So I didn't ask a question. I answered your question. I think you said, what do you do? So actually what I did, and the other thing that they did for my father that they did different is they did move him to ICU, but he had MRSA, and they picked up all of his things from the windowsill, the other bed in the room, took everything down the hall to the ICU, wheeled a clean bed into the room without cleaning it. So I saw it from both the nurse and the patient perspective. And you asked if they'd made change, and yes, they did. I wrote letters. I went to my state legislature. I won't go into all the things that I did, but anyhow, they made the change of isolating all patients. and they didn't have any nosocomial MRSA the next year. My father was the third of 3 that year. So thank you so much for your work and your story and sharing your story. It's important that we all do that. Thank you.
Thank you. It's a fantastic accomplishment. I think hospitals need to find ways to culturally transform so that patients can feel comfortable speaking up. And there's still a real deep regret that I have for not really getting much more outspoken and aggressive in the wee hours of the morning. Having said that, I've also learned now, though, that if you have a safety system within a hospital that relies on patients raising a ruckus in order to get the care that you need, we're probably in trouble. So I think we're always going to need both sides of these mechanisms, but especially with sepsis care, where we are still in that 10 to 15-year window where knowledge is being brought out into the public, into the clinical space. I think we need to keep both of those things in mind, and patients being able to speak up is incredibly important.
Hi. My name is Kristen Lind, and first I just want to say thank you so much for sharing your story. It's really powerful. Can you hear me now? Okay. So my name is Kristen Lind, and Christine, I'm kind of the classic mom turned advocate. My son is 10 years old. He has a genetic syndrome called Coffin-Lowry syndrome. Not that rare, not that common. But I'm just here to share a really short example of something that's happened recently that I think speaks to one of the hugest barriers that we have when we talk about this subject, which is culture. So 2 weeks ago, I was reading a Swedish medical publication. The title of the publication roughly translates into Dare to Let Patients Partner. And I was so excited to hear about what the Center for Person-Centered Care at the University of Gothenburg was doing. The fact that they even acknowledged that it was person-centered care and not patient-centered care, I thought was significant. I made a comment to the article and talked about some of the work that I'm doing here in the US and supporting what conclusions they had come to. So I support family and patient partners who are working in quality improvement teams. You just wrote a great article, Christy, which I keep quoting left and right. Thank you so much. And I was really surprised because about 24 hours later, I noticed that my comment was gone. And I was a little bit nervous because I wrote my comment in English, even though I do speak Swedish. My husband is from Sweden. And I just dropped them a note and said, did I do something wrong? You know, I want to be able to make sure that I can stay part of this conversation. Well, I got a reply back about a day later saying that your comment was removed because you're not a professional healthcare worker. So it's a very short story, and conversation has continued with this publication. My comment has been restored, but I think that nevertheless, their stance is that patients have a lot of space that they get to take up in the media, and there need to be places where we protect professional voices and allow them to be able to speak frankly and openly with each other. So I just sort of lend this little anecdote as a litmus test or a barometer of kind of what we are facing as we talk about partnering with patients, because my new mantra is culture eats strategy for lunch. I mean, it just is really going to come down to that often. So I just share that, and I want to say thank you so much for making sure that patients have such a strong voice here. It would have been really easy to do something else, so thank you so much.
Thank you very much. We continue with the us versus them, and I don't think healthcare providers want to be in that position as much as patients as well. So we're going to take one comment from Paul Grundy in the room because we do want to get into our next session, and if there's anything from the web, maybe you all can bring that up as well. So Paul, please go ahead.
Thank you, Jonathan. I have a couple of questions. The first question I have is,
The sound is still too low.
the first question I have is, what was the total cost of that experience for your mom in the hospital? Do you have any idea?
It's a great question, and I'm still working to dig through her charges.
Yeah, I think, the time magazine article is worth reading for
Yeah,
all of us who
absolutely.
haven't done that. And I guess the second thought I had is that you and I, as physicians that grew up in the world of Flexner, in which we're master builders, right? I mean, we look at the world not in the view of data or accountability towards data, but in a world where we're master builders. I mean, you wouldn't have done that in that system if it was somebody who was constructing your house and you saw an error occurring, because there would have been a plan and accountability to that plan that would have been happening in the system. And I guess the fact now in healthcare is we're moving away from Flexner towards a model of care in which there is going to be data and there's going to be accountability to data. And I think we need to think about that in reference to how the consumer engages with that data. Clearly, the experience in places like Denmark and others is to make sure that that data is available to the patient, right, to the consumer, to the person, as a clear element of that. But I mean, the system that you encountered with your mom is a system that's so flawed and so broken, and the structure of it is, I mean, it just has to be frustrating for you. And you express that frustration so well by not knowing quite what to do at any stretch of the imagination, because you know down the road there's going to be blocks put in place for everything you really try to do. But I mean, that's changing, because for the first time in history, we're going to have the data to begin to hold a system accountable, and a place where that data flows in a medical home where accountability begins to occur. But my question for this group and for us is, how do we really guarantee that the consumer, that the patient is part of that? Because that's going to be absolutely essential. Thank you.
Yeah, it's a great and a great point. I too am hopeful as slowly but surely we move to these systems where we're holding our healthcare system accountable for results. And I think the hopeful thing is that we're building an evidence base that shows that these tools, patient activation, patient engagement, even from a very utilitarian standpoint, to say nothing of the intrinsic good of centering on patients, that improves results. And if people if people and the citizens are paying attention to results, and hospitals and clinics are getting paid for results, I think this will become part of a larger package that transforms care.
So thank you again, John, for your terrific story, and also for giving us some insight into a productive way forward. I think my summary of that session would be defined as it's all about culture, stupid. And I think John's story does a terrific job of illustrating that while we keep saying, well, gee, if patients would just get active in their care, we would, really have a better system. But when they get active, what we heard from the audience, what we heard in John's story, is that we tell them, no, they can't be part of the care team. No, they can't have their notes. No, they have to get limited to visiting hours. No, you can't be part of designing what this primary care practice looks like. We're going to design it for you. And that's the system we have today, right? So I'll say two things as we jump into the next session. One is I'm thrilled with the level of audience engagement and the fact that you guys are getting up not just to ask a question, but to offer your viewpoints and your experiences, and I want that to continue. And I say, I know we're running a little late, which is something that I raise only because I don't want to rein in the audience, but I do want to give a heads up to the speakers that we want to leave time for exactly this interaction. The second thing that I would observe is that the central theme of this discussion so far has been about partnership. So as we go forward and we hear from some absolutely phenomenal experts in the field and people with really innovative programs to build on, and that's our goal, right? Figure out how to build on what has been successful so far. Look for that theme of partnership and where it's happening. And if you don't see it, we should ask about it, and we should find the ways. Not everybody has done it, and they can still succeed. So we need to find the ways to bring bring that partnership into even the most successful strategies so that they can be accelerated and even more impactful. So with that, I'm going to turn it over to Lynn Padgett, who's going to moderate our next session. We're going to spend the rest of the day focusing on shared decision making, and Lynn is one of the world's foremost experts, and she is the managing partner at Health Policy Partners. So thank you.